Hello class. For this pharmacology project, I've chosen to discuss the use of hydantoins in seizure management. The pharmacological class of the drug is hydantoins. The therapeutic class is anticonvulsants or anti-epileptics. The objective of this particular pharmacology program is for the audience to be able to describe the indications, the precautions, the therapeutic use, and adverse reactions of hydantoins, particularly dilantin and fosphenytoin. The audience will identify the 3 known hydantoins used clinically in the management of seizures, and the audience, that being nurses, will be able to describe the pregnancy risk, which is category D, and that is confirmed by evidence of fetal risk. However, the benefit may warrant the use of this drug despite the known risks. An example of that is somebody in status epilepticus, and if there's a pregnant woman in status epilepticus, there is the chance of hypoxia to the fetus. So the doctor has to make the decision on whether or not to utilize hydantoin, fosphenytoin, or IV dilantin. To define seizures, seizures are a sudden and transient disruption in neural activity in the cerebral cortex caused by an unorganized discharge of electrical activity. Seizure is not a disease, but a symptom of underlying CNS dysfunction. Therapeutic agents used to control seizures are classified as anti-epileptics or anticonvulsants. Seizures are classified as partial or generalized. Partial seizures are subcategorized into simple or complex. Generalized seizures are subcategorized into tonic-clonic, atonic, status epilepticus, absence seizures, myoclonic seizures, or febrile seizures. It's important to note that status epilepticus can be a life-threatening event. The longer status epilepticus goes on, the greater chance of permanent neurological damage can occur. Febrile seizures, however, occur with kids, typically under the age of 5, associated with fever or an infectious process. However, they typically don't use anticonvulsants to manage febrile seizures. They treat the seizure and the infection, and that's all that's typically indicated when managing febrile seizures. Anti-epileptics work in 3 distinct ways. One, there's the inhibition of sodium transport by binding the sodium channel, impeding the neurons from firing. 2 is preventing the calcium transport into the cell, inhibiting transmission of electrical current from calcium. And 3 is prolonging the effect of GABA. GABA is gamma aminobutyric acid, which is a neurotransmitter inhibitor, and we'll get to that a little bit more on that in a second. These first 2, inhibition of sodium transport and the prevention of calcium transport, really is where the hydantoins work. In short, they stabilize the cell membrane from ionic activity, thereby inhibiting the transmission of electrical current and stabilizing the cell from firing rapidly. And that's where the hydantoins work. As I said, GABA is a neurotransmitter inhibitor, and the drugs that prolong the effect are Valium, which is diazepam, Versed, which is midazolam, and lorazepam, which is Ativan. We'll get to those a little bit longer, but what they do, GABA is a naturally occurring substance in our bodies, in our body chemistry, and they prolong the effect, thereby decreasing or inhibiting the conduction of nerve impulses through the synapses, causing rapid contraction to relax or subside. And that's how the benzodiazepines work. Diazepines work in managing seizure. Hydantoins have been around a long time. They're the first class of anticonvulsants utilized to manage epilepsy. They were discovered in 1938. They're around almost 80 years, so this drug has been tried and true. These drugs have been tried and true, particularly Dilantin, for a long time. There are 3 drugs in this category. One is phenytoin, which is Dilantin. I have the dosing listed. You can see the dosing. Adult doses, PO 100 milligrams TID. Of course, if somebody's in status epilepticus, you're not going to give PO Dilantin. You might give IM Ativan, or you might give Valium PR. But the PO dose is 100 milligrams TID. The IV dose is 10 to 15 milligrams per kilogram. However, it is often ordered, and I've seen this ordered, and there's an article that I'll refer to later that indicates that it is often ordered 1 gram IV in the case of status epilepticus in an emergency room setting. The pediatric dose for PO administration is 5 to 8 milligrams per kilogram per day, and IV is 5 to 10 milligrams per kilogram in divided doses. And then there's Peganone, which I've never used clinically. That's also a hydantoin. The adult dose is PO 2 to 3 grams per day, divided into 4 to 6 doses. And then there's, for pediatrics, it's 500 milligrams to 1 gram per day. And of course, then there's fosphenytoin, also known as Cerabix. The adult dose is 5 to 20 phenytoin equivalents per kilogram IV, and that can go at a rate of 100 to 150 phenytoin equivalents per minute. The therapeutic goal of hydantoins is to prevent the prevention of tonic-clonic seizures. It's the control of status epilepticus. It's for the treatment of seizures post-surgery, post-neurosurgery. The nursing considerations for hydantoin, specifically Dilantin, the side effects are slurred speech. They kind of slow you down neurologically, neuromuscularly, so you can have a slurred speech, you could have confusion. And of course, with long-term use of Dilantin, there's well-documented gingival hyperplasia, which is the overgrowth of gum tissue on the teeth. They become inflamed. The drug interactions, hydantoins compete with antiplatelet agents like aspirin at receptor sites, thereby increasing the antiplatelet activity. If hydantoins bind to the receptor sites, then there's going to be, consequently, there'll be more of the aspirin or the antiplatelet in the serum, which will increase the antiplatelet activity. Tagamet is also identified as a drug that can increase the action of hydantoins. Herbal therapy interactions include ginkgo, which may decrease the effect of Dilantin. Evening primrose can decrease seizure threshold when taken with anti-epileptic agents. When given intravenously, never reconstitute Dilantin with dextrose to avoid precipitation. Intramuscular injection of Dilantin can cause tissue damage. It's a tissue irritant, so never give Dilantin IM. Question that if you see that. Nursing considerations, more of the nursing considerations to consider. Frequently assess IV site for irritation, inflammation, presence of necrotic tissue. As I mentioned, Dilantin is a tissue irritant. Assess for pregnancy. Dilantin, as we said earlier, is pregnancy category D. There's a clinical decision to be made by a physician if somebody's in status epilepticus, and there's the potential harm to the fetus is greater from the status epilepticus than the administration of the Dilantin. It potentially interferes with vitamin K, which plays an important role in blood clotting, thereby increasing the risk of fetal hemorrhage. We should also monitor for cardiac arrhythmias in patients receiving IV phenytoin. And you think about it, blocks the ionic channels in nerve tissue. So could that potentially block calcium channels, causing arrhythmia? That's something to consider, but it is well documented that patients receiving IV Dilantin should be monitored for arrhythmias. They should be on a monitor when they're receiving the Dilantin. We should also monitor the serum phenytoin level. With any drug, we want a therapeutic effect. So too low of a dose, it will be non-therapeutic, and we're at risk for seizure, and too high of a dose could be toxic. So the therapeutic range is 10 to 20 micrograms per ml. We monitor adverse reactions, liver toxicity, Stevens-Johnson syndrome, drowsiness, confusion, and Dilantin can also cause bone marrow suppression. It's important to note the safe administration of hydantoins, particularly the look-alike, sound-alike circumstance with Cerebix and Celebrex. Cerebix is used for seizures. It's a hydantoin. Celebrex is an NSAID. They're very, very closely. They're very, very similar in spelling and pronunciation. Fatal errors with Cerebrex. There's a peer-reviewed article I found in the Journal of Emergency Nursing that reported numerous and sometimes fatal errors regarding administration of fosphenytoin. Research and root cause analysis show clinicians were misinterpreting the dosage. Some clinicians gave 10 times the ordered dose. An investigation revealed 10 ml vials were labeled 50 phenytoin equivalents per ml, and some nurses thought the entire vial contained 50 phenytoin equivalents, when in fact the entire vial contained 500. The result resulted in a tenfold increase in dosage. Collaboration with pharmacies regarding storage, labeling, and distribution was recommended after this study. One of the big things that they said was we should just distribute smaller vials. We should distribute 2 ml vials, which is 50 per ml, and remove the 10 ml vials, thereby reducing the risk of that drug error. An article in the American College of Emergency Physicians regarding best practices of seizure management in the ER indicates, even though that Dilantin's been around forever, benzodiazepines, which also have been around a long time, not quite as long as Dilantin, benzodiazepines are the first line treatment in the management of seizures. This article lists lorazepam, midazolam, and diazepam. Again, Ativan, Versed, and Valium. These drugs can be administered IV. Valium could also be administered PR if there's no access, IV access. Hydantoins are considered as the second line of treatment, and typically what is ordered is phenytoin, Dilantin, or fosphenytoin, Cerebix. This article identifies fosphenytoin as the safer of the choice because of the lack of potential precipitants from the diluent. So this article is stating that Cerebix is the safer drug, fosphenytoin when giving this drug IV. I've worked in a particular place with all they gave was Cerebix IV for status epilepticus. And then that was a big medical center. And then I did work in another facility, and you go out a little bit further out of the city. This is on the East Coast. You go into the suburbs, and you're in a little community hospital, and they don't have fosphenytoin. They have Dilantin. Again, so they're not the same drug. They're similar drugs, and there's different safety considerations for each. So in summary, these drugs have been around a long time. They're effective. They work. But there are safety considerations to consider. They're not the first line for status epilepticus. A lot of patients are on Dilantin to prevent seizures. For seizure prevention, I composed a patient safety handout. I will also include an attachment, but it's what I entitled it, What You Need to Know About Taking Phenytoin Safely, and it's right here, and I'll briefly go over it. It's it's composed for a patient education, and it states you'll be taking a drug classified as an anticonvulsant. Sudden interruptions of this drug, Dilantin, is dangerous. This drug needs to be tapered gradually over time with doctor's supervision. Inform your doctor if you feel you're unable to tolerate the side effects of this drug. Common side effects are headaches and insomnia. However, these can subside as your body adjusts to the medication. Follow the frequency of the administration consistent with your doctor's instructions. Dilantin must be taken regularly. And wear a medic alert. Do not take with alcohol, as alcohol increases the speed of metabolism. Do not drive. Participate in dangerous activities, as drowsiness may occur until your body adjusts. And you should always talk to your physician about your ability to drive. If you're taking oral suspensions, shake it rigorously to thoroughly mix the medication to ensure you receive the proper dose. The drug can cause severe complications during pregnancy. Inform your doctor if you're taking evening primrose or ginkgo. These herbal drugs may impact the effectiveness of Dilantin, and you will need to follow up with your doctor to monitor blood work regarding your Dilantin level. So thank you, class. Thank you for letting me present this presentation.